Welcome to this presentation on the ISCHEMIA trial and the question of whether initial revascularization improves outcomes in patients with stable coronary artery disease, CAD, and moderate to severe ischemia. Today, we'll discuss the findings and implications of this important study and review key evidence guiding management in stable coronary artery disease. Let's start with the clinical question. Does revascularization through procedures like PCI or CABG improve outcomes for patients with stable coronary artery disease and a high ischemic burden compared to medical therapy alone? This question stems from the theoretical benefit of targeting high-risk ischemic areas, but it has been a topic of debate, particularly after previous studies. Historically, the COURAGE trial in 2007 showed no survival advantage of PCI over medical therapy in patients with stable angina, sparking a debate. COURAGE critics argued that the study did not represent patients with a higher ischemic burden, potentially leaving out those most likely to benefit from revascularization. Subsequent studies, including BARI-2D, investigated PCI benefits in higher-risk subgroups, but yielded inconclusive results. These findings set the stage for the ISCHEMIA trial, designed to evaluate revascularization versus medical therapy, specifically in patients with moderate to severe ischemia. The ISCHEMIA trial was a multi-center, randomized controlled study enrolling 5,179 patients with stable coronary artery disease and moderate or severe ischemia on stress testing. Patients were randomized to either an early revascularization strategy with PCI or CABG or optimal medical therapy alone. This trial took place across 320 sites in 37 countries, adding diversity to its participant pool. The study's primary outcome was a composite of cardiovascular death, myocardial infarction or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. Follow-up was conducted over a median of 3.2 years. The study population had notable inclusion criteria. Participants were adults with moderate to severe ischemia, identified by various stress tests, including nuclear imaging, echocardiography, and cardiac MRI. Exclusion criteria included recent acute coronary syndrome, unprotected left main stenosis 50%, severe left ventricular dysfunction, and advanced heart failure, among others. Baseline characteristics show a population at relatively high cardiovascular risk, with a median age of 64, 41.8% diabetic, and 73.4% hypertensive. In terms of interventions, the revascularization group received medical therapy plus angiography and PCI, or CABG, for significant ischemic regions. For the medical therapy group, angiography and revascularization were reserved only for cases where medical management failed. During the trial, 96% of the revascularization group underwent angiography, and 79% underwent revascularization. In contrast, only 26% of the medical therapy group had angiography, and 21% eventually had revascularization before experiencing a primary outcome event. Now let's turn to the primary outcomes. For the composite outcome of cardiovascular death, myocardial infarction, or hospitalization, there was no significant difference between the two groups over the follow-up period. By 5 years, 16.4% of the revascularization group had experienced a primary event compared to 18.2% in the medical therapy group, yielding a hazard ratio of 0.93, 95% CI 0.8 to 1.08, p equals 0.34. In secondary outcomes, there were similarly no significant differences in cardiovascular death or myocardial infarction rates. The all-cause mortality rate also showed no notable difference. Interestingly, the ISCHEMIA trial found that procedural myocardial infarctions were more common in the revascularization group, highlighting some risks associated with early intervention. In the revascularization group, MI rates were notably higher within the first 6 months, largely due to procedural complications, which underscores an early risk associated with revascularization. However, by the 2-year mark, the event rates for MI became similar between both the revascularization and medical therapy groups. Over a longer follow-up, 3 to 4 years, the revascularization group even appeared to have slightly fewer events, suggesting a potential long-term benefit. Further analysis across various subgroups found no significant benefit of revascularization based on differences in baseline ischemia severity, the anatomic severity of coronary artery disease, or presence of diabetes. This reinforces the conclusion that revascularization does not provide a clear outcome benefit for any specific patient profile among those with stable coronary artery disease and moderate to severe ischemia. There are, however, limitations and criticisms of the ISCHEMIA trial to consider. The study did not meet its original enrollment target, which may have reduced its power to detect smaller outcome differences. Additionally, there were statistical complexities due to the violation of the Cox proportional hazards assumption and a 21% crossover rate in the medical therapy group, which likely attenuated the observable effect of revascularization. The higher rates of early procedural MIs raised questions about the risk-benefit balance of intervention, which may influence clinical decision-making. As of early 2021, no updated guidelines reflect the findings of the ISCHEMIA trial, but the study's results do suggest a shift in clinical practice. For patients with stable coronary artery disease and moderate to severe ischemia, optimal medical therapy alone should generally be the primary approach. Revascularization may still be considered for symptom relief or specific indications, such as left main disease or persistent angina, despite medical therapy. In conclusion, the ISCHEMIA trial offers strong evidence that in stable coronary artery disease patients with moderate to severe ischemia, initial revascularization does not improve outcomes compared to medical therapy alone. These findings support the primary use of medical therapy, with revascularization reserved for carefully selected cases.